So last time we had just finished talking about whooping cough, bordetella pertussis, and so today we want to take a look at tuberculosis. Mycobacterium tuberculosis is a very serious lower respiratory tract infection, but people don't understand that Mycobacterium tuberculosis is not just a lower respiratory tract infection. It can infect every single organ of every single tissue of the body. And so it's important for us to understand how this infectious agent is transmitted, and it's transmitted through droplet nuclei, right? The etiology of tuberculosis is Mycobacterium tuberculosis. Symptoms typically are associated with it are low-grade fever, a chronic cough. Some people report that they're very tired, right, because their immune system is at war, if you think about it. Night sweats for some individuals, right? And then patients who have active tuberculosis, either in their lungs or their larynx, just by simply coughing, if they have in their lungs, they're spreading the infectious agent. And if it's in their larynx, if it's in their voice box, just by talking, um, they can be spreading the infectious agent, right? The infectious agent has that mycolic acid cell wall, and so it's hard to destroy. It's hard to kill. It's hard to kill with antibiotics. It's hard to kill um, with a lot of other types of conventional things that we used to kill other types of microorganisms. But the one weakness that TB has is UV. UV is deadly to it. And so a lot of times when we have TB wards and things like that, they have HEPA filters, and it's a negatively pressurized room, like we talked about when we talked about control, and all the currents on the hallway come into the room. They get swept up into a HEPA filter, and up in that HEPA filter is a UV light, right? And so that's a really good way of destroying tuberculosis, right? So TB in all other environments where there is no UV, so let's say in somebody's carpentry shop or in a shipyard, right? If people have tuberculosis and they are expectorating, if they're spitting out that TB bacillus into the environment, into the ground, it's just going to stay there. It's going to be viable for a long time. And when people walk around and kick up the dust, that tuberculosis bacillus can be kicked up and be breathed into the lungs, um, and then people can acquire TB in that manner. A long time ago, tuberculosis used to be known as an infectious agent of the dusty trades because of the dust involved with it. But now we know that it really is aerosolized. It's really the the coughing, the sneezing, and the generating of droplet nuclei from the body, and that gets into the airways like we've seen before, and people breathe that in, and then they come down with TB, right? You can get TB from being exposed once, but that's usually not the way it is. It's being exposed over a period of several different episodes, right? So my uncle had TB when I was a young kid in Corpus, and I was one of his caregivers, and so I would stay with him, um, part of the week and take care of him while he was trying to get better. And I never serologically converted to being positive for tuberculosis. So, you know, m- I got trained on how to work with him, right? So, but I never serologically converted to be TB positive, right? You all, as healthcare professionals, will be exposed to tuberculosis. This it's a it is a you will be exposed to TB. But if you follow the correct procedures, you're not going to serologically convert to be TB positive. Okay? Questions? All right. So if we think about it, it's one of the, I don't know if it's the second anymore, right? I have to look at the numbers again, but it is one of the largest, biggest killers in the world, right? In the United States, right? Because I know the numbers in the United States better than I do the world. There's about there's about 300,000 incidences in the United States, so new cases on an annual basis, right? In the United States, it has about a 10% mortality rate, But in the rest of the world, it has about a 75% mortality rate. And that's just simply because you are blessed to live in the United States, whether you believe that or not. Um, and we have a lot of resources here, right? And so, because tuberculosis is considered a public health threat, if you don't have the means or the resources to pay for treatment, that will be provided to you for free by our public health system, right? And therefore, everybody who has TB can be treated. Or a large, we see a large, we see a lot of morbidity in our prison systems, right? And we see a significant portion of the homeless population have symptoms of tuberculosis, right? But they don't go seek medical treatment, and therefore we're not sure what's going on. And when we have tried to get them to come in so that we can look at them, they're just not willing to do that, right? Humans, we mount a significant immunological response to tuberculosis in our lungs, and that's what causes a lot of the damage to our lungs, right? So it's just not the bacterium that's actually doing the damage. It does damage, but our cell-mediated immune response does a lot of the damage to our lungs also. Okay, so here is a radiograph showing, man, this is hugely, you can see almost all the lobes of the lung are really, really infected with tuberculosis. These nodules that you see throughout, the lungs are tuberculosis. This is what it looks like. A patient, of course, who expired, and you open it up. This is what TB looks like in the lungs, right? Now, this is a pretty extreme case, right? Usually you have maybe one or two nodules in the lungs itself, but still, that's you have the tuberculosis organism. You have Mycobacterium tuberculosis in your lungs, and it is a significant health threat, not only to you, but to anybody who you come in contact with, right? There are two stages of tuberculosis. We call inactive and active. A lot of people will call the inactive latent, right? It just go dormant. And what that means is typically when you get exposed to TB, you inhale the droplet nuclei into your lungs, and in those droplet nuclei are tuberculosis, right? And so it gets into your lungs. It gets into your lungs, and I told you that the body's pretty magnificent, right? If it can't destroy something, which it has a hard time destroying TB, what it does is sequester it, right? So it forms these colliculi, these calcifications around the tuberculosis bacillus, and those are what we know as gone foci or gone tubercules, right? And so they can stay there for a long period of time. You will test positive at this point because you have tuberculosis, and therefore you have the antibodies against TB, and that's what we look for. Um, but you don't have active TB at this point. It's still very treatable and very curable, right? And so we are trying to do that. You guys, as healthcare professionals, will probably have to undergo a yearly screening for tuberculosis, whether that be a titer or a tuberculin skin test, right? And I'll explain what those are in a little bit. And in worst case scenarios, if you test positive for tuberculosis because you've been exposed or in the past, or you've had the vaccine for it, right, which we call the BCG, you're going to test positive for TB forever. And so in those cases, we can do titers or we can do Xrays to make sure that you don't have an active case of TB, right? Okay, so here you can see the difference between latent and active tuberculosis, right? And so I'm not going to expect you to know this. What I have just told you, right? Latent or active TB, you've been exposed to tuberculosis, you test positive because you have the antibodies, and we're looking for the antibodies. And but the organism is latent; it's dormant in your lungs. Okay. Active TB, you have an active infection, and you're going to have the symptomology associated with that active infection, which remember is cough, fever, weight loss, tiredness, um, night sweat, all those things that we talked about already, right? And so you can see that the tuberculosis skin test is what we use as a screen, right? Um, you can see that the skin test is called the Mantoux, but most people just call it the tuberculin skin test, which is I prefer that, right? It's easier to say. And then you can see chest X-ray are kind of the gold standard, right? If you have a normal chest X-ray, even though you have latent TB, um, we will treat you for it and cure it. But if you have an abnormal chest X-ray, that means we see active infiltration of the lungs, of the lobes of the lungs. Then there's a whole different type of treatment regimen that we go through. And sometimes it's just not curable, right? So here again, you can see are the gone foci or the gone tubercules, right, associated with TB. Here you can see it in the upper portion of the lobes of the lungs. And then here you can see it kind of as a diffuse infiltrate, but a little bit of the calcifications you can notice um, for the tuberculosis foci, right? Here's a definition of gone complexes. I just want you to know that those are the sequestering of the tuberculosis bacillus in the lungs, right? The body does that, and then they stay dormant until you get treated, or at some point in your life you get stressed out again, and the tuberculosis bacillus starts to actively grow, and then you move from having inactive or latent TB to having an active case of tuberculosis, right? So here you can see is an artist's illustration of the gone foci or the gone complexes, right? And then here you can see in the lungs the actual gone foci, those calcifications of the lungs, the caliculi, if you will, where the tuberculosis has been sequestered. But eventually, convention says that you'll go under some kind of stress and the tuberculosis bacillus will begin to grow and you'll have an active case of TB. Okay. So, okay, talked about that already. Active TB, you have an active infection, right? You have the organism growing your lungs. A lot of times it'll show up as a diffused infection. These are this this particular image, this radiograph shows tuberculosis and the upper portions of the right and the left lung, right around the medial portion of the lungs, and the lower lobes are really infiltrated. You can see that kind of cloudiness, that diffuse growth within the lungs themselves, right? And in this case, you have an active tuberculosis infection, and it can be really serious. In this case, we would have to cure this patient because it is in both lungs. Sometimes, if the patient only has tuberculosis in one of the lungs, and it's a pretty resistant form of TB, we can go in there and resect the lung, remove it, right, and we get rid of the problem that way. But that's done in extreme cases where we know that that the the tuberculosis bacillus that's in that patient's lungs um, is resistant to a lot of the anti-tuberculosis drugs. Right. Okay. This is a purified protein derivative. You need to know that purified protein derivative is the actual substance that we put right underneath the skin, and it's also called the tuberculin skin test. Right. This is the standard by which we do things with. This is what I prefer. Right. Is to add about 1/10 of a cc right underneath the skin, right, with a tuberculin syringe and needle. This is the TB time test here, right? And it went away for a while because the people who were administrating it, nurses, were doing a lot of, were not doing it correctly. And when they were doing this, they were causing a lot of damage to the tissues where we actually administered the test. And we saw what we call induration, right? We saw the wheals, the inflammation of the injection sites, and people were having a hard time considering them to be positive or negative. So we took it away. It's been designed a lot better now, and so it's come back. And some people are using the tuberculin time test, like this one, right? Um, but this is still the gold standard. This is what I prefer, right? It's real cheap to do, right? So you come back, and nowadays, because there's so little TB, I say that, but there's several million people in the United States that have TB. When you have 320 million, that's right. So this one in HIV/AIDS. If you are non-compliant with your treatment, you are considered a public health risk and you can be arrested. Yeah, because you are a risk to the public, right? So it's not really with Lyme disease or anything like that, but with AIDS and with TB, they are considered to be, if you're not compliant and you are exposing people, James, you can be arrested for it. Yeah. Anyway, getting back to these are indurations, right? And what you would do is you would measure it with a ruler in millimeters, and 8 millimeters across would be a positive, right? That doesn't mean that you have TB. What that means is you've been exposed to TB, and you have the antibodies, right? Now you might have been exposed a long time ago, and your body took care of the infection, but you still have the antibodies. Remember, antibodies, immunoglobulins, are for life. So if you come in contact with the infectious agent, you're going to have the antibodies for life, right? If you had the vaccine, the BCG, the Bacillus Gangrene, you're going to test positive for the tuberculin skin test for life because you have the antibodies. You've developed antibodies against the vaccine, not against the bacterium, right? But still, you're going to test positive. So in that case, you're going to have a chest X-ray or a titer in order to prove that you don't have an active case of TB. Okay. So if we think about this for a minute, right, with treatment, it's really about the different ways that we do our screening, right? And so you're about to go to nursing school, right? And you get the PPD, right? If you get the PPD and it's a negative, then you are a happy camper and you're going to go do great things. Okay. If you get the PPD and it's positive, now we have to work you up, right? And what that means is we have to do a titer to look to see if it's warranted for us to do further investigation, or we can quickly just do a chest X-ray, right? If we do a chest X-ray, we can look for the infiltration. If this comes up negative and you have never been treated for TB, CDC recommends that we treat you for about 3 months. Sometimes it's up to 6 months with one of the more common anti-tuberculosis drugs, which is isoniazid. Okay. And once you get treated, you should always keep that treatment as part of your history, because if you change jobs and you go through this process again and you don't have any proof of treatment, they're going to treat you again. Okay. So save your documentation. However, if you test positive for the chest X-ray, that means you have an active case of tuberculosis. The recommendation for CDC is 12 to 24 months of treatment, because they're hard to kill, of 2 or 3 anti-tuberculosis drugs. So that is typically isoniazid and rifampicin with ethambutol, and there's others that you can use, right? But the 2 big ones are isoniazid. It could, James. And so I don't, it would be pretty rare, James, that it would be like this, right? But it does happen, infrequently, but it does happen, right? So isoniazid, and rifampin. And those are the two most important, as far as I'm concerned. To me, they're the best. Now, there is multi-drug resistant and extremely drug resistant TB that these drugs won't work against. And so you have to use other drugs. And what I will tell you is the other drugs are really, really toxic to us. Now, isoniazid and rifampicin are toxic to us also, right? So we have to do on schedule. We have to do liver enzyme studies to make sure that your liver is not being destroyed by this. And you shouldn't be drinking alcohol or taking other types of analgesics that are hard on the liver, like some of the NSAIDs, right? So you just have to be really, really careful when you're being worked up for TB. Take it seriously, right? As James said, it's one of these things that if you're not compliant with your treatment, then you can be arrested, right? So the way that they do this is they will be on the honor system first, right? And so they'll give you the drug and you'll just say, please take it as indicated, and then they'll basically tell you, here's how you have to take it, right? And then you come back in 3 months and you get refills, and at that time they may take a little bit of blood and they will check for the levels of these particular anti-tuberculosis drugs in your body, and if they are at the levels they're supposed to be at, then they're going to consider you to be a compliant individual and they're not going to do anything else. If they check the levels and they're not there, they're going to put you with the case administrator, and the case administrator will come to your house every day and watch you take the anti-tuberculosis drugs. Okay. And if that doesn't work, then you're considered a non-compliant patient and you are told to sequester yourself. And if you don't sequester yourself, if you go out in public and endanger the lives of other individuals, you could be arrested. Okay. Any questions? This is serious, right? This is a serious infectious disease, as AIDS is. The difference between AIDS and tuberculosis is that with AIDS, the reason that organism, that infectious agent was put on that list was because there were people who knowingly had AIDS and were still having sex with other people, right? You may have heard some of those stories. We had one of those in San Antonio and one of those in Houston, right? But both of those people got put in jail for, I forget what the charges were, and one of them is still serving time, right? But with TB, the difference is just by coughing, you can spread tuberculosis. Okay. Questions. Becoming a healthcare professional is not a job for a hypochondriac, right? So if you are afraid of everything, you might consider a different career path. Questions. All right. This is just explaining some of this. Multi-drug resistant tuberculosis we have in the United States. Extremely drug-resistant tuberculosis we do not have in the United States, but it is on the Asian continent, right? It's in India and it's in Africa. So it's just a matter of time before it comes here, but there is no treatment. Therefore, there is no cure for extremely drug-resistant tuberculosis, right? We can try second or third class anti-tuberculosis. Those things are really toxic to the body. Or we can resect one of the lungs if it's only in one of the lungs, right? But other than that, we just simply don't have a lot of other means or ways to treat people with extremely drug-resistant TB. Okay, it's really, really expensive to have a patient who has extremely drug-resistant TB. And so we try to do our best to educate the public, and you guys are going to be part of the education process because as you become healthcare professionals, right, especially a nurse, because you're going to have a lot of interaction with people. Dental hygienist also. Surgical technologist, not as much. Excuse me one second. Because most of your patients as a surge tech are gonna be thank you, Nelda. Most of your patients as a surge tech are gonna be under the influence of anesthesia, and so you're not gonna interact with them too much. But we wanna be sure that if somebody gets diagnosed with extremely drug-resistant TB, that they know that they have a very, very serious infection and that they can spread it, so that they are compliant individuals and walk around with masks, right? So when they go out in public, so the likelihood that they're gonna spread it is not very great. There are other infectious agents to the same genus, Mycobacterium, that cause atypical TB, right? So these are Mycobacterium avium intracellular complex. This is MAC. This is what causes a lot of problems in our AIDS patients, right? Mycobacterium gordoni and Mycobacterium keynesii. Those are other infectious agents that are related to TB, and so we say that they cause atypical TB. But in order, by the insurance definition, in order to be TB, it has to be it has to be identified by a clinical laboratory as being Mycobacterium tuberculosis. Okay. In the late 50s, early 60s, we had TB backed up into a corner and beaten down. Because in those days, if you had TB, we would send you to a sanitarium. And we would send you to a sanitarium really to die. We said, oh, we're going to send you to this place. There's treatment rooms that are, self-sealed. You can engage with other people. You can sit out in the sunlight because the sunlight is really healthy for you, and sunlight kills TB. And we gave you all this, you're going to a resort, but really it was you're going to a chest hospital, you're going to a sanitarium to get you out of the general population, right? And then the laws changed with civil rights and civil liberties, and so it became it was not possible to sequester individuals because they had infectious diseases. It was against their civil liberties. So now we only can arrest you if you're a non-compliant individual, right? There are no sanitariums around anymore. There are remnants of them, right? If you go to the Chest Hospital of San Antonio, that used to be a sanitarium. And if you walk around in there, you might be able to see kind of the way it was structured so that individuals could be sequestered when they had a really, really fulminant and, in fact, contagious case of TB. Okay. Anybody have any questions about anything we've talked about in the respiratory tract? Okay. Done with respiratory. Let's go now to talk about infectious diseases of the cardiovascular, circulatory system, and the internal organs, right? So it's we're having problems, right? The organisms out there are becoming superbugs, right? So here are just a few of them. There are a lot of them, but here are just a few of them, right? So you can see Acinetobacter baumannii, right? Streptococcus pneumoniae, Haemophilus influenzae, Staphylococcus aureus, all the salmonella. In the world, Salmonella typhi causes typhoid fever. We don't have typhoid fever here, but it is pretty close to here. It's in the Caribbean, right? Pseudomonas aeruginosa, Enterococcus faecium, and Mycobacterium tuberculosis. All of these organisms are known to have drug resistance to our antibiotics, and there are a lot more, right? There's just a few of them. But so we are at a point in our society where we're going to start to see more deaths associated with infectious disease. Now, as I showed you when we talked about the infection of the skin, in the rest of the world, right, respiratory infections and diarrheal diseases kill a lot of people, not so much in the United States, right? Take COVID-19 out of the equation, right? That's a different type of infectious agent. But if you take that away from it, then there are a lot of infectious agents that are killing people throughout the world, not in Europe and not in North America, including Canada, right? Because we have the infrastructure to treat these things when they become a problem, right? When we talk about systemic infections, right? We're looking at those things that are related to being in the body, and we're talking about the entire body. So usually that means that it has to be in one of the fluid matrices of the body, either the blood or the lymphatic system. Therefore, it can be encroach in every single part of the body, right? So septicemia is an older term. Almost nobody uses it anymore, except for older physicians who might say, well, it has septicemia. And that usually meant that they have bacteria in the blood, because that's typically what we see in a hospital setting, right? There are better words to describe that. Bacteremia is a better word that describes bacteria in the blood, and that's what I want you to know. If you have a virus in the blood, it's viremia. If you have a parasite in the blood, it's parasitemia. And if you have a fungus that's in the blood, it's fungemia, right? And so we have different ways of looking at that. In the United States, on an annual basis, there's about, the M is 1,000, it's not a million, but it's 500,000 on an annual case. It's higher than that now, right? I need to update the stats here. But in the United States, it has about a 23% mortality rate, right? And 10% of those individuals who die already have some other underlying disease or comorbidity, right? They're diabetic, they're morbidly obese, they're fighting cancer, all these different things, right? And so you have to get to number 13 down on the list of things that kill Americans to get to septic infection, right? And therefore, there's just not a lot of resources that are put into finding new and novel antimicrobial agents that can help us with this problem. Because drug companies can make a lot of money. Right now, the drug companies are really hooked into this life-changing mechanism, right? So if you have cardiovascular heart disease, they're making drugs to treat so that it slows down the progression of the cardiovascular heart disease. If you have cerebral vascular disease, if you have hypertension, so they're treating the disease instead of really kind of getting to the culprit, right? Instead of saying, okay, take this Lipitor and take this hypertensive drug and it'll help you with your health. Instead of saying you need to lose 40 pounds, right? We decide to do this other thing, right? And so we're becoming a lot more unhealthy as a population, right? And so we're going to see those increases of infections start to really hurt people because drug companies are not doing the clinical trials to get these antibiotics to market right now. I worked for 4 drug companies, right? 4 good ones. And we had a lot of antimicrobial agents in our inventory that had not even been put into clinical trials. But the reason we didn't put them into clinical trials is because it costs the drug company a lot of money to take these things to clinical trials, and they're not going to make a lot of money off of these antibiotics. So they're not going to spend the time to do that when they can make a lot more money treating Alzheimer's or treating all these other types of problems that we have in the United States, right? Right. So if we just think about the septic infections that people can acquire in a hospital, it's an expenditure of about, let's put it right in the middle, about 7.5 million, a billion, I'm sorry, billion on an annual basis, right? Just to treat people who go into the hospital and get sick in the hospital because they develop a septic infection or a nosocomial infection there, right? And it can become hugely problematic, right? When people have bacteremia, when people have bacteria, they're infectious agents, this cascade shows up, right? So it's hard to read here, but it should be easier to read when you look at the presentation, right? So you have an invasion of the infectious agent, the immune system responds, there's a cytokine release, right? The organism and the cytokines and the cells and proteins that they're recruiting, right, cause the coagulation of blood, and then septic shock septic shock can happen, right? Mostly with gram negatives because of the endotoxin, right? Which then can lead to multiple organ dysfunction syndrome, right? Usually it's the liver or the kidneys that go first, and then the other one follows really quickly, right? Because those two are the really the cleanup crew of the body, right? So the kidneys and the liver, one of them goes, the other one follows because it can't keep up. And if you have the liver and the kidneys involved, then you're in serious trouble, and it's going to put a huge amount of pressure on your heart, and you're probably going to arc out and die. Okay, and then death follows, right? Um, so we have a vested interest in trying to keep ourselves healthy, right? 50% of all the sepsis infections that are seen in the United States um, are are with gram-negative rods, right? The number one cause. You should know that for the exam. Other etiologies include CNS. That does not stand for the central nervous system as it does in anatomy and physiology. CNS stands for coagulase negative staphylococci. That's all the staphylococci that's not Staph aureus. And then you have Staph aureus, the Enterococcus species, both faecalis and faecium. And then you have fungi, things like Cryptococcus. Okay. We believe that the numbers of sepsis are predicted to increase and continue to increase because of the following reasons. Number one, the large numbers of immunocompromised patients in our society. And that's not just AIDS patients, but that's people who have myasthenia gravis, have Crohn's disease, Ray's disease. They're morbidly obese, they're fighting cancer, all these different things, right? The more frequent use of invasive procedures or devices. So we know if our patients need a replacement of a knee, a hip, or a shoulder, like I did, we can replace that really effectively, right? I have about an 86% range of motion on my left shoulder, which I had none when my shoulder was completely destroyed. So, these are good things, right? But it's an invasive procedure, right? The greater availability of life-sustaining technology. So we're talking about dialysis or hemodialysis, things like that, right? It's an amazing thing. I don't like it that they're trying to push people to do dialysis at home by themselves because it's a cost cutter. To me, we're just asking for trouble, right? We're just asking for people to use contaminated materials and infect themselves with this. I just think dialysis need to be at a dialysis ward or a dialysis unit, and let's just keep it that way, right? What do you mean, Nelda? Are you saying that home dialysis costs more to the patient? Tell me why.
They have to have the recommendations in regards to the filtration for their
Yeah.
water, and then they have to have a certain type of sewage tank to go from where the unit is at. I work in dialysis, so
Oh, I know that.
I know.
I know that. So you told me that. But tell me, then why would people agree to do that?
Just because it's more convenient for their time.
Okay. Well, that's
Most patients agree that they want to be able to do it whenever they can, and since usually at least the critical patients that we have, they have to come at certain times, and it's inconvenience for them.
Yeah.
It's
Okay.
an issue for work and so on.
Yeah. So my mother was a dialysis patient for 8 years, and they kept trying to do that. They kept trying to say, "Well, let's do it at home." I'm like, no. I said, "This is stupid." I said, "My mother's already fragile, and you want to put her at risk. Well, you can do this." I said, "Yeah, but I don't live in Austin. I live in Austin, Texas. I don't live in Corpus Christi. So I have an aunt and a sister who might be able to help." And I said, "They're not very good. So no." So to me, it was explained to me by the case person, Nelda, is that the the insurance that my mom had wanted to do that because it was cheaper for the insurance company to do it that way. So that's why I made that statement. So I appreciate the perspective, right? Um, I didn't know because my mother and my aunts, who both have been on dialysis, they never said anything about, well, I'd rather do this on my own time. No, they never said that to me at all. So that's an interesting perspective. What is the percentage of individuals, Nelda, that you think want to do that? 80%. Wow. Okay. Thank you, Nelda. I'm gonna have to talk to some of um, my nephrology physician friends and find out what's going on. Thank you. Yeah, yeah, it could if you're working, right? The people that I was dealing with were not working. They were older. Yeah. All right. So anyway, higher infection rates because of antibiotic resistant bacteria, and also the increased proportions of patients at the extremes of ages. So in the United States, we're getting older and we're having less children. So now there is a baby boom going on right now with the individuals that are millennial. They're and really the Gen Zers, but they're having babies at a pretty rapid rate. So we're seeing that there's there's this whole phenomena about pandemic babies. I don't know if you've heard of it, but there's a interesting thing going on right now where there's a baby boom, but mostly we're just getting older, right? Yeah, yeah. So it's an interesting phenomena to think about. But we have the ability to have a preemie delivered very early in the gestational period. The preemies can fit in your hand, right? And we can care for them, nurse them, so that they can live a perfectly normal, healthy life at a huge cost, but important, right? Yeah. So those segments of the population, the elderly, right, and the extreme, um, the very new to the world citizens are very susceptible to infections. Okay. Yeah. So we're going to see these types of infections increase over time, right? Okay. All right. Let's talk about some of the infectious agents, right? Gangrene. So again, associated with people who have problems with comorbidities. So in the clinical settings that I've worked with, and I have made it part of my live submission to help diabetic patients, mostly because my family members were diabetic, my mom. Um, so I've seen a lot of diabetic patients. When I was in grad school in San Marcos, um, I was exploring the possibility of being a nurse, and I met a physician at a volleyball game, and he invited me to come and be part of his practice. So I was his medical whatever, and I did all his full body work. I did all his Xrays. I did a lot of his debriding, and he taught me how to suture. So I did his suturing under his direction. Well, we had several diabetic patients come into the clinic. On one of them, the doc looked at me, and it was a elderly Hispanic man, and his grandson brought him in. And the doc looked at me and said, "Felix, we can't do anything for them. Send them to the ER." And the doc talked to the patient, and I came in, and the grandson told me, "We can't really afford to go to the ER." And I told him about EMTALA, right? Um, they still said, "We really just can't afford to do that. What can we do?" And I said, "Well, what you can do," I told him, "Look, I'm not a doctor." So he said, "Okay." But I said, "Take Epsom salts and put your dad's foot in Epsom salts and massage it real good and try to get some of the blood to flow down there, right? And he said that that was a really good thing, because he came back about a month later and he said that they did eventually have to go to the ER, but the physician at the ER said that whatever they had been doing was working because they weren't going to have to amputate any of the part of the foot because it was savable at that point, right? Because these organisms that cause gangrene are anaerobic. And if you can get some of the oxygen to effuse into the tissues, you might be able to save. Now, if it's necrotic like this, right? If it's like it's black like this, it's dead already. So you're just going to have to amputate. But in the case of this person, it was in the early stages. I don't know if you've seen it, but the skin starts to turn kind of bluish, right, and blistery. And so he was a the grandson was able to save his grandfather's foot because he did that, right? But the etiology for these things is usually it's a mixed infection of organisms, right? But the culprit, the one that causes most of the damage, is Clostridium perfringens, and you need to know that for the exam. Okay, so there can be others. It can be anaerobic staph. It can be anaerobic strep. There can be other infectious agents that cause this, right? And gangrene is it is a term that catches a lot of different processes, a lot of different pathologies that just mean that there's necrotic tissue. So you can have frostbite causing gangrene, you can have trauma causing gangrene, or you can have an infectious agent cause gangrene. And so it can be pretty serious, right? So here you can see, it's called gas gangrene because the organisms are anaerobic, and when they're anaerobic, they produce a lot of gas in that process. And so here you can see the kind of the blisters, the serosanguinous fluid-filled sacs with gas that are being produced on the foot, right? And then here you can see one of the patients who you can see all the necrotic tissue. A lot of the necrotic tissue was removed. And then you have this opening where they can then treat, right, with antibiotics, but also with hyperbaric therapy. And so you need to know about hyperbaric therapy. Hyperbaric therapy is a way to increase the pressure around a particular limb of the body or the whole body. So you have little bitty devices where you can put your arm in it, or you can put a leg in it, or you also have these devices here that that you can put the whole body into. And in some places they have hyperbaric rooms, so you can go in there and the whole room is pressurized and they are pumping in pure oxygen, and this pure oxygen is getting into the body and it's effusing through the tissues, and anywhere there's an anaerobe, it's going to kill it. Nilda, do you guys use hyperbaric therapy at your hemodialysis center? No? Okay. So my mom, uh, my mom, I think if I tell you the story, tell me so I won't tell the story again. Yes, yes, that's exactly how you do it. You know, it's James. I don't know, but I don't know if you guys know, but when people go, not me, when people go diving and pretty deep in the ocean, they can get the bends. And one of the ways we treat the bends is for hyperbaric therapy. We reestablish homeostasis with pressure within the body. So here's a way that you can infuse more oxygen into those tissues of the body. And as oxygen gets into those tissues of the body, because these organisms are anaerobic, they're not going to survive, right? My mother, yeah, my mother was a diabetic, and she had several incidences where the diabetes, the disease, did not allow her to appreciate that she was hurting herself. So when when older Hispanic people warm up tortillas, they don't stick them in the microwave, right? They turn on their gas burner and they put a tortilla on it and then they flip them over, right? And that's the way they heat up tortillas. Well, my mom did that, but she didn't know that she had burned her 2 fingers on her right hand, and she couldn't feel the pain because of the neuropathy. She knew something was wrong, but she covered it with gauze, like, and wore a glove, which is the worst thing you can do, because now you have a lot of moisture being developed in there, and that caused her to have an infection. Now we got that one under control. But the second real incident was she was walking around, and she got a tack into her heel of her left leg, and that tack broke off, but the little piece of metal was still in there, the little pin, the little head of the tack, if you will, the pin of the tack, and it caused Clostridium to get in. And my sister called me and said, you need to come down. There's something wrong with mom's foot, and she won't let me see it, because I told my sister, I said, every day when you say goodnight to mom, because my sister was married, lived at like 3 blocks away, but my mom didn't want to leave her house. I said, check her feet, right? And you want to look for any kind of wounds that are on her feet, any kind of cuts. But mom would not show her feet to my sister. So when I got there, you know, I knew there was something wrong because the house smelled terrible. And I said, Mom, I need to see your feet. And so she treated me differently because I was meaner than my sister and my brother. But she showed me her right leg pretty quickly, but would not show me her left leg. And so I said, I need to see it. And so I said, I'm going to have to see your foot. And I pulled off her shoe, and it was filled with serous sanguineous fluid that was really, really very, very foul. And I pulled off her sock, and it was gangrene. Put her in the car and rushed her to the hospital. They debrided, right? They used hyperbaric therapy to try to save the foot. I was, because I had worked at Spine Hospital as a young folk in orthopedics. I knew a lot of the physicians there, and the surgeon came up to me and said, we need to talk. And so we talked, and he said, look, if we don't get this infection under control, we're going to have to amputate. I said, I understand. So the next day, the surgeon came up to me, and my mother's nephrologist, and they said, looks like we're going to get the infection under control. So I was good, right? This was Sunday morning. I came back to Austin, and then Tuesday, my sister called me and said, you need to come down here. They want to amputate mom's leg. So I went and got down there. My sister had already told the physicians I was coming, so they were waiting for me when I got down there. It was about 2 o'clock in the afternoon, and they showed me the X-rays, and so you could see where the infection had completely digested the bone of the foot, right? And so it was spreading upward from the foot. It was gone and now into the leg, and it was right kind of about the medial point of the leg. And the surgeon looked at me and said, we need to amputate to save, but your mother won't sign the form. I said, I'm the medical fiduciary. Let me have the form. And I signed it. And I said, when can you go ahead and amputate? So tomorrow morning, first thing. I said, good. So I went in my room, and my mother, usually she would hug me and, say hello. But she said, don't you let them take my foot. I said, Mom, tomorrow morning you're going to have surgery, and they're going to amputate your leg right below the knee. I said, and they're going to do this to save your life. And she started crying because my mom was like that. She thought that if she cried, that we would feel bad and we would change our mind. That doesn't work with me. So I gave her a box of Clinics, and I said, I'm going to go get some coffee, and when you finish crying, we can talk, right? Which just infuriated her. My sister said, I'll come with you. And my mom said, no, you stay, right? Because my mom was going to work on my sister to try to get my sister to change my mind. Came back, and we have a plan, right? What if I am better and I follow all the rules that you have? Will you let me keep my? I said, no, it's different, Mom. You're gonna die if we don't amputate your leg. So she started crying again, but she finally calmed down. And the next morning they amputated her leg. But the thing was, the process there was they left it open, right? I would have thought they would have formed a stump and put a stump in and then used an evac or a Penrose to let it drain, but they didn't do that, left it open. And the surgeon looked at me and said, this is the way that the resident, the chief wants us to do it from now on. I said, we're gonna have an infection again. I said, he said, and it gets worse because your mother's insurance will only pay for 2 days in the hospital. So we're gonna have to send her home with home health. I said, we're gonna be back here in a couple of days with a raging infection. And that's what happened, right? So 2 days later, I'm in Corpus again, and now they amputate my mother's leg above the knee. And this time they put a stump in, and mom gets better. She convalesces, and she lives another few good years before the diabetes takes her life. But every time we were at Christmas or some other family gathering, I would whisper in her ear, "Aren't you glad I let them amputate your leg? Look how much fun you're having." And she would look at me and said, "I don't want to talk about that," because she knew that I made the best decision for her and that she was wrong. But that's the way that Hispanic moms are, for those of you who don't know that, right? And that is a true story. I have the X-rays, right? So, yeah, when you become the medical fiduciary, as I was the medical fiduciary for my father, and I was the medical fiduciary for my mother, and I'm the one who basically turned off when my father was dying. I'm the person who asked the nurse to turn off the feeding tube, to remove the feeding tube, and uh, I asked her to give another dose of morphine, but she couldn't do it because there wasn't an order, right? I said, look, he's in a lot of pain. They said, well, if we give him another dose of morphine, it could kill him. I said, he's going to die anyway. He's in a lot of pain. So the physician came in and said, if we do this, he could die. I said, he's in a lot of pain. So they gave him another dose of morphine, and it calmed him down. But then he went into the guppy mode, right? So I don't know if you guys ever seen that. People die very differently, and he died gasping for air, right? So he was like, kind of like guppies do when they're in the water and they're stressed out. So he did that for about an hour, and then he just simply stopped breathing, right? Gastric cancer metastasized and took his life, right? You have to be able to make those decisions because you do not want the people who you love to suffer. And where we can't really, in the state of Texas, do any kind of euthanasia, maybe you can now, but in those days you couldn't. And so what you do is you try to do the best things for your loved ones that you can. So yeah, so you have to be really, really careful that you can communicate with people. Now, nurses can't do things for you, so don't put them under pressure like I did, right? Don't tell them, give them another dose of morphine, because they can't. But you can say, I really need to speak to the physician. It's an emergency, right? And then they'll get the physician, and the physician is the only one who can help you when your loved ones are in that much pain, right? So it's interesting because my father was a very big extrovert, and he wanted to die with a lot of people around him, and he did. My mother was a very big introvert, and what she said is, I want to die in my sleep, and she did. Um, Nobody was around. I had put her into an assisted living home because she fell and she hurt herself, and she was in a lot of pain, and we could no longer take care of her. Um, so that is a no-no in the Hispanic world, right? So I was highly criticized by a lot of my family members, not my brother and my sister, but my aunts and my cousins. But there was just no way that I could see that we could take care of her with the kind of care she needed. And so she passed away at about 3 o'clock in the morning when everybody was asleep. And we got the call about 7 o'clock in the morning that she had passed, right? Which is the way my mother wanted to go. She didn't want any kind of fanfare. My dad was different. He wanted to go out with everybody around him, right? And that's just the way people are. It's pretty interesting. Uh-huh. Well, that was a while back now that I've had time to adjust to that. But I like to tell the stories because both of them are have been, you know, both of them are associated with microorganisms. My mom had died of diabetes, but she had infections of gangrene. And my dad had an infection of Helicobacter pylori, which then caused him to have cancer, which then took his life metastatically, right? So I like to make those connections. Um, yeah. Well, I mean, it is true. I mean, I think every death, James, is worth telling the story of those deaths because it gives grief and it gives people validity to their life, right? But I'm hoping that people also learn from my parents and take better care of themselves. And it gives you a clue as to the power that you're going to have as a caregiver, right? Um, yeah. So that's why I do this, right? It's important to get through the content, but it's also important to relate the content to real life situations, to real life scenarios, right? Um, because you can see how these things can affect a lot of different things. And hopefully you'll see it and it'll make a little bit of an adjustment in the way you do things so that you become a better caregiver, right? Let's go on. Plague, Yersinia pestis, right? It is an enteric. It's related to E. coli, but it causes three different types of clinical manifestations, right? It causes pneumonic, septicemic, and bubonic plague. Pneumonic of the lungs, septicemic of the blood, and bubonic of the lymphatic system, right? Um, in the early stages of plague, you can have fever, delirium, swelling of the lymph nodes, and if it becomes septic and goes into the lymphatic system, you can develop this hemorrhagic rash, these lesions. That's why it's called Black Death. But also the lymph nodes can become swollen to the size of a tangerine. And so that's why it's called bubonic plague, because these swelling of the lymph nodes in the either the neck or the anangle area or the armpits, right, or the wrist, they're called buboes, and so they're an indication of having plague, right? At least bubonic plagues. Pneumonic plague is the most dangerous, right? Because it's in the lungs, and people talking, coughing, breathing can transmit the infectious agent to other people, and that's the way it can become an epidemic, right? So plague has got two really important players, right? Um, one of them is a varmint, right? And here, you're looking at the rat, but it can be a squirrel, it can be other organisms, right? But the rat kind of gets all the big play, right? Because that's what happened with Black Death, right? And then the flea. Well, the flea is the vector, right? And so you need to know that the rat and the squirrel are reservoirs, and the flea is the vector, right? And so when the flea squirrel, it gets Yersinia pestis into its body, and when it bites a human, then it can transmit the infectious agent via the bite to the human, and then the human can develop plague, right? Here are some of the buboes, right? Here's a wrist bubo, and here's kind of under the armpit, these buboes that show up, right? Um, okay. My system is saying it's okay. Is everybody else having a problem? Okay. So Barbara and Lucia, I don't know what's going on, but you might want to like leave and come back uh, if you can hear me. Okay. Okay. All right. So treatment is usually several different antibiotics that are taken at the same time, right? And each of them have a different mechanism. Now, the one time I dealt with a plague patient, we used streptomycin and chloramphenicol and tetracycline. It's probably different now, right? Because there's a whole list of different antibiotics. I should actually take a look at my new book that I just got and update this. But but it really takes a multifaceted antibiotic approach to get rid of this. Now it's treatable, right? We can treat this and people can recover and have no problem. But if it doesn't get treated, it can become pretty serious, right? So here you can see that half of all bubonic plague patients die if not treated. But if we treat, the death rate goes down to only 5%, right? So here you can see the lesions, that why it's called Black Death, and here is the buboes in the inguinal area of this particular patient's body. Plague has been in art and in stories and in all kinds of different things, right? Because when people don't understand what's going on, they make up stories uh, to to try to describe what's going on, right? Kind of what happens in politics, right? But here you can see this is death coming across and taking lives in both of these pictures, right? Or both of these art pieces of art. And so as it comes, as death is coming through, it is taking lives, right? Um, and so if we think about that, for those of you who don't know, Ring Around the Rosies is really about plague, right? So just now here I'm going to tell you the way it goes, at least the first few stanzas, right? Yep, check it out. Ring around the roses, pocket full of posies, ashes, ashes, we all fall dead, right? That's the way it goes. Now it's been changed now to go ring around the roses, pocket full of posies, a tush, we all fall down, right? Because the some of the younger generation didn't like the fact that it was really talking about death, and changed it so that it's more kid friendly. Mm-hmm. So yeah. So ring around the roses. Why roses? Well, typically people say different reasons, like you stand around roses when you're at a funeral, but roses can also be from the kind of the red rash that develops early on in the progression of the disease. Pocket full of posies. Posies are these real fragrant, um, these little fragrant flowers. Um, yeah, that the fragrant flowers were actually used by men to put in their pockets so that they smelled good when they didn't have deodorant, right, back then. But also posies could be put on the bodies of the dead to help with masking the stench of death, right? So ring around the roses, pocket full of posies, ashes, ashes, because we would burn the bodies of people who had plague, right? Thinking that if we burned the bodies, that plague would go away. But the problem was, ashes, ashes, because we burn the bodies, we all fall dead. The reason we fall dead was because plague wasn't just in those bodies, plague was in the fleas and in the rats. And so every time we had to get rid of the rats and we had to get rid of the fleas in order to get rid of the problem, right? And so then you have another piece of folklore that comes through, which is the Pied Piper of Hamelin, who actually mesmerized all the rats, right? Because of the magistrate at that particular city, London, was going to pay him a lot of money if he mesmerized the rats and took the rats out of London. And so he did, and the magistrate wouldn't pay him, so it gets worse. He mesmerized all the kids and took all the kids away from London until he got paid, right? Yeah, so a bunch of folklore, a bunch of stories have been tied to this particular infectious disease, and it's pretty cool to think about, right? If you ever see a copy of the Pied Piper of Hamelin, an old copy, let me know, because I collect old texts like that, and I would like to try to buy it. Um, might not be able to, but I'd like to. Right? Pretty cool. This was at the National History Museum at the Smithsonian. This is an oil. It's not a photograph, and it's I don't remember the name of the artist, a real famous artist who drew who painted an oil buboes on the neck of this particular person. I got in trouble with the docent because I got really close to that painting. I couldn't believe it was an oil, uh, and the docent yelled at me. But anyway, so you can see death has been kind of depicted in a lot of pieces of art. It's an amazing thing to think about how that happens. Closer to home, right now we do have plague in West Texas. We probably have 2 cases of plague in West Texas on an annual basis. And when I say West Texas, it's really I-35 and west of I-35. So on east of I-35, no problem. but usually it's in West Texas. It's out there in the Marfa, that kind of area, right? But we do have it. But closer to home, there's Lyme disease, right? Lyme disease in Texas. I think James brought this up. I think he's familiar with it up in the Northeast. But in Texas, it is also spread by ticks, right? Amblyomma, the Lone Star tick. And the reservoirs here are numerous, right? Deer and a bunch of other things. I'll show you a list of them in a minute. But this is a gram-negative spirochete, and it produces a very, very complex infection. If it gets diagnosed very early on, it can be treated with no problem, right? But the problem becomes if it's allowed to manifest itself deep into the tissues of the body. And if it does that, then it's really hard to treat. And it mimics a lot of other diseases, right? So it's hard to diagnose, right? Here you can see this person's got Bell's palsy, right? But also you can see this bullseye rash right here, which is a combination of erythemia. Yeah, not all of them look this good, right? But this is a combination of erythemia, redness, and edema, swelling, right? And it's becoming a lot. Yeah, it's becoming a lot more prevalent than I would like it to be in Texas. And so you just have to be on the lookout. And I'm not saying be afraid of nature. I'm just saying mitigate risk, right? So you can see all these different animals, right? Mice and squirrels and small animals and deers. They can all become the reservoirs for Lyme disease. One of the things I should update is this map, because this map is showing kind of the clustering of the infection. So you can see most of the clustering started up here. As a matter of fact, it's called Lyme disease because it was first characterized in a little town, Lyme, Connecticut, by a physician, by William Burgdorfer, who the organism is named after, right? Borrelia burgdorferi, right? But it is a very complicated infection, right? And so the really big time specialists who deal in Lyme disease, two of them are in the Northeast. One of them is in Texas. And what they basically say, because I've been to several conferences where they gave talks on treatment of Lyme disease, is you have to have a long-term antibiotic therapy in order to treat patients with Lyme disease. That's the only way we're going to be able to do it. But the rest of the American Medical Association does not agree with that. And so there's a lot of controversy about, who should you believe? Well, I'm going to believe the specialist guys, right? Because they're the people who've been doing most of the research and most of the treatment of people who have these really complicated infections that we call Lyme disease. Okay, questions? Brucella. So the reason Brucella is on here is because we had an outbreak in Seguin, Texas a few years back. It was in a company who was making immunoglobulins, and they had goats and sheep, and they didn't have really good practices, and so there were several cases of Brucella that were associated with that particular outfit. USDA came in with FDA and they shut them down. But when they did swabbing of bathrooms and kitchen and computers of that particular building, that business, and 60% of all the swabs that they did came back positive for Brucella, right? Brucellosis is also known as undulant fever, right? And so there are several different species that can cause undulant fever. Brucella abortus is typically associated with cattle. Brucella melitensis is associated with goats, and Brucella suis is associated with pigs, right? But there can be others, right? It can be deer, elk, even dogs, right? Can be the reservoir. And so if you come in contact with this infectious agent, right, it can move systemically pretty quickly, right? It's known as undulant fever because you get really high fever at night. The day, your temperature is pretty normal, right? And so you can see that it can cause not only septic infection, but it can cause inflammation of the joints. And so it can be hugely problematic. Okay. If we look at the CDC website, it'll tell you that that of the human cases that are reported in the United States, 60% are those individuals who are butchers or meat packers, 30% are ranchers or hunters, and hunters who field dress their own game, and then 10% are people who consume unpasteurized dairy products. Right now, it's hard to find information in the United States because it's just not as prevalent here. But I went to some of the Mexican websites and I found some stuff down there because it's more prevalent down there. Right. And at this point, I wanted to spend a moment talking about blood cultures. That's one of the ways you can get it. Yeah, other way, wounds, things like that. Right? I want to talk about blood cultures, right? So with blood cultures, when we do that, we're taking blood and we put it into two different environments. We put it into an anaerobic medium, right, what we call tryptic soy broth. Has a lot of nutrients that will grow everything. And then we also put it in fluid thioglycolate, right? So for those of you, if you remember, one of the first things we talked about this session was this media, fluid thioglycolate, that allows for the stratification of organisms based on their need for oxygen. So we put the blood in that also, and that's where the anaerobes are going to show up, right? So then we then will evaluate this test for 14 days. And after the 14th day, if it's still negative, then we can call the test negative, right? But not until the 14th day, because there are some organisms that are real slow growing, like Brucella, which may show up on day 13 or day 12, right? And so it is a problem that we need to be able to find the organism. Treatment is usually done by giving two different antibiotics, doxycycline and rifampin, for about 6 weeks, and it takes care of things, right? And if we treat, then we cut down the mortality rate to less than 2%, which is really good. But if people do die from Brucella infection, that's usually because the infectious agent gets to the heart and causes endocarditis, and therefore it can be a real big problem. Okay. Tularemia. This is one of the bad boys. So the two organisms that you're going to hear from me in this unit 5, that can be really, really serious are Francisella tularensis, causes tularemia, and also Shigella, because both of those organisms, Francisella and Shigella, only need 10 cells, right, to cause an infection, and therefore they can be hugely problematic and easy to disseminate, right? Francisella is an organism that's capable of surviving for a long period of time in water, in soil, in hay, or decaying animal carcasses. It is a lot of times it's disseminated by different organisms. A long time ago, it used to be called rabbit fever because it's normally found in rabbits and hares and things like that. They're the natural reservoir, but there are other reservoirs, right? Voles, mice, water rats, squirrels, and then of course rabbits and hares, right? And so this is problematic. It can be disseminated by dust. It can be disseminated by coming in contact with the rabbit. So especially if you're a hunter and you field dress your own rabbits or deer, because it's in deer, or it can be disseminated by the bite of a deer fly. And so I don't know if you've ever seen fly, this is what it looks like. Deer fly are pretty aggressive and they hurt, right? The horse flies are bigger, but they're not as aggressive. They'll bite you if they have an opportunity. A deer fly will attack you. It'll come at you, right? It's hungry. And so you can see that that's one of the ways that people can do that. So coming in contact with the organism because you have a cut or a break in your hand, you're field dressing your animal and it's there, right? Or through the bite of a flea or a tick or a deer fly, or by ingesting wild game that is not cooked all the way through, right? With wild game, you should cook it all the way through, right? A lot of people will complain that that it takes the taste away from it, but you got to mitigate risk, right? And so with tularemia, it starts out if it's on the hand or wherever, because you field dress your animals, it starts out with an ulcer, and then it moves into the body and gets into the blood, and then it can cause all kinds of different problems, right? To me, if I saw this type of an infection, I'm going to be thinking it's a staph or a gram-negative enteric, and then You do a little bit of workup and you find, oh no, it's something a lot different. Tularemia is extremely dangerous because it has the virulence factors that it can resist the phagolysosome. So it gets phagocytized, but once it's in there, it multiplies, right? It resists that formation of that phagolysosome that we talked about with phagocytosis. And it uses the phagocyte, the macrophage, as a place um, to grow and replicate. And then it causes apoptosis in the cell that it's infecting, and they all get released, and then they can cause a problem, right? And so this is a really important characteristic of Francisella. Any questions about Francisella? An infection that I put in here because people kept asking about it. Well, what about cat scratch, right? Well, people always think that cat scratch is a lot more serious than it is. It's not very serious, right? There are about 40,000 cases of cat scratch fever that are reported, and therefore they're part of the CDC database. But for the most part, it's just not a problem, right? Bartonella. Yeah, yeah. So Bartonella is the etiology, right? And it can be transmitted by the bites or the scratches with cat because it's in the saliva. And so when it scratches, you can see that you have these little pustules, right? Um, or you can have a little lesion like this that show up, right? And, you know, it's swelling of the lymph nodes, maybe fever in some patients, could be fatigue, malaise, a little bit of headache. But for the most part, it's a self-limiting infection. The immune system takes care of it pretty quickly, and there's not a problem, right? So again, with cat scratch fever, you can treat it with antibiotics, but usually it's not a problem, right? Um, yeah, there, yeah. This is. I'm surprised. I think you're kind of young, James. I don't know how you know about Ted Nugent, but Ted Nugent was a rock star. Um, oh, okay. Ted Nugent was a rock star, right, in the 70s and back when I was listening to rock in the 80s. And he had a really famous song called Cat Scratch Fever. Um, yeah, and now he's a different person, right? That's true. But Cat Scratch Fever was not really about Barton. It wasn't really about cat. It was about a sexually transmitted infection. If you ever get an opportunity to listen to his lyrics, they're pretty fun. But now that you've taken microbiology, you'll be able to discern that he's not really talking about cat scratch fever. He's talking about a sexually transmitted infection. Okay. Chagas disease. So we talked a little bit about this again. I want you to know about Chagas disease for the exam. I want you to know that the etiology is Trypanosoma cruzi. It causes Chagas disease. And what we see typically is, of course, that's the triatome bug or the kissing bug, and Bell's palsy is one of the symptoms. But this can be a problem in Texas. And really, it's going to be a problem because as we see that as this disease progresses, that it causes problems with the heart, right? Cardiomyopathy and also digestive abnormalities. And so we're going to see a problem with this in the United States. It's already here. It's been here for a while. There have been at least 10 cases reported endemically to Arizona. And while the organism has also been reported in Texas, I just went to before the summer session started, I just went to a conference virtually for diseases in nature, and they were talking about Chagas disease endemic to Texas also. So it's here, right? It's just a matter of time before we start to see more cases, and so you can see that death is usually when heart disease sets in because of the damage that gets done um, to the heart by the infectious agent. Lots of different symptoms, right? You're not going to need to know that. You just need to know that Trypanosoma cruzi is the etiology. It causes Chagas disease, which people die mostly because of heart disease or heart problem. Okay. Last organism for the day is Toxoplasma gondii. Now we've talked about this a little bit, so um, We're going to talk about it again when we look at lab today. But Toxoplasma gondii causes toxoplasmosis. Now, this particular infectious agent has the ability to infect every single tissue of the body, right? And although it's associated with birds and other things, the number one reservoir that we see associated with are cats, right? And so, you know, pregnant women get a lot of education with this particular infectious agent, even though having abortion associated with toxoplasma is extremely rare. We spend a lot more time educating pregnant women to not clean out the litter box, right? So you should know that, because most of the infections that are associated with toxoplasma are really about food. It's the contamination of food or utensils or undercooked foods when there's a cat in the house, right? And so cats are pretty stealthy. You put some chicken out to bake it, and the cat will jump up on the counter, put their paw on the chicken, maybe lick the chicken, jump back down, lay on the ground, and you never even knew that the cat came in contact with that chicken, right? But during that process of coming in contact with the chicken, it could have contaminated that chicken with the oocyst of toxoplasma. And so it's really important to make sure that if you have a cat in the house, that you cook your food really, really well, um, especially if there's a pregnant female in the house, right? So the cats themselves, they are very interesting little creatures. They are natural hunters, and when when they get a chance to get out, they are going to hunt, right? They're not like dogs. Dogs like to explore everything, right? But cats are they're on the hunt the whole time, and sometimes they'll bring you back little presents. They'll bring you back birds or lizards or snakes or whatever, and they want to be rewarded with a pet or something, because they brought you a prize, right? And so, if you think about this whole cycle of coming in contact with the cat, because that's the one we're normally going to come in contact with, right? But it's because they're killing birds and mice, and the birds and the mice are the natural reservoirs, and so therefore the cat becomes domestic reservoir for the oocysts, right? And we come in contact with the oocyst, and then we can develop infections of toxoplasmosis. Now, most of the time, almost all of us, 85% of us, will test positive for the antibodies against toxoplasma, but we didn't even know we had it, because our immune system is so good that we really don't appreciate infections by toxoplasma unless you are immunocompromised, right? And so if you're immunocompromised, then you can really, really see this. So that's good, Lucia, but your cat, um, if it gets out at any one time, it's not only exposed to toxoplasmosis, but probably even to feline leukemia virus. So just be sure you're aware of it. Okay. Pregnant women should never ever clean out the litter box, right? Um, and and the other person in the relationship, um, when they're cleaning out the litter box, they need to treat it like normal trash. They need to put the litter, the poo and the urine, in a plastic bag, and then seal it up and throw it in the regular trash. Right? Cats are really, really kind of finicky organisms. They get in the litter box, and what they do is they will clean an area so that they can do their business. But if there's too much poo or urine already in there, their paws may come in contact with them, and then they walk around your house with the oocyst of toxoplasmosis. Okay, so here's an image. I like it mostly because of the cat. So um, I don't think you need to get rid of the cat, but don't let the immunocompromised cancer patient clean out the litter box. Okay, Miss Lakeisha? Because I will tell you that we do see studies, and the studies tell us that for immunocompromised, and it's really mostly looking at AIDS patients, that there's a trend right now where we're seeing ocular toxoplasmosis, which is causing damage to the eyes of the immunocompromised, which is leading to blindness in our AIDS patients, right? And so that's something that should be reported, because it is happening. right? I don't have any data on other types of problems that other segments of the immunocompromised populations in the United States are going through. I just don't have that. But I, I, I get several different periodicals on a daily basis, and I go through a lot of these and pick up things that are important. Sometimes I send you them. Sometimes other students send me stuff, and I think they're important. I'll send them out to you. But there's just a huge amount of information that's coming out on a daily basis. You can't keep up with it all. Okay. I sometimes think that a lot of people are just afraid of everything. And that's not what this class is about. This class is not meant to scare people. This class is meant to help people understand the interaction of the microorganisms with us as humans, because we're pretty self-centered and we just really want to think about us. And so as we become more health conscious and become on the path to become a health professional, I want you to know these things are out there, right? And you're going to run into these things, but I don't want you to be afraid of every single E. coli that you come in contact with. Okay, ladies and gentlemen, that is the end of the lecture for today. So we have covered in Unit 5, we have covered diseases of the skin and the eyes. We've covered respiratory tract diseases, and we've covered systemic infection and diseases. We still need to do urogenital and nervous. I have sent you a video about the gastrointestinal infections. Please take a look at that sometime this weekend, so that you'll be ready for our last exam 5, right?